SDMC Udupi to take over the session. Welcome, sir.
The next is about Raktavaha srotas. In the Raktavaha srotas, the description is Raktavahidve Taiva Moolam Mekakulihano Raktavahinyasthadhamanyah Tatra Vidhasya Shavangata Joro Daha Panduta Shonitagamanam Raktanetralacha. The vascular system is the Raktavaha srotas, and in the vascular system, it's the importance of Yakrit and Pliha is mentioned. So it's not that it is suggestive of a fetal circulation. I don't accept that theory, but it's that about the functions of the improving the oxygenation. The basic oxygenation is based upon the hemoglobin, and the hemoglobin synthesis occurs in the liver, and there is a major role of that. And then of course the oxygenation enters into the body through the pranavaha srotas, through the respiratory system. So it's all that srotas is not something like which is exclusive, they are integral. And Sushra has given the importance to the synthesis of the hemoglobin for the functions of the Raktavaha srotas. So probably it could be that way. And of course the srotas is not simply, or when we say cardiovascular system or the blood vessels there, the blood vessels are not simply one single system. You have multiple systems, like the whole of the cardiovascular system has multiple circulatory structures. The hepatic and the hepatic portal structures one area, and then the upper part of the body has another segment. The head and other areas, superior areas, they also have another segment as it. Renal structures, that's again another of the segments. So vascular vessels, cardiovascular system, which we say as the systemic circulation, it's not as such a single system. You have two issues. One, the pulmonary circulation, where the oxygen enters in and the blood is pumped through the heart, and then the heart also pumps the blood into the individual systems as such. So it's absolutely justified, like if you say either the Yakrit has the major area or the pulmonary area has the major area, it doesn't make much of a difference. Now as far as the injuries to the Raktavaha srotas are concerned, in the Sragata Shalya, the description is if there is an injury to the trauma to the Raktavaha srotas, it results in Siradhanam, Sirashulam, Sirashopascha. Now we will come back to the issue of circulation, how the nourishment occurs, and the regulation of the circulation. See, regulation of the circulation is not only by the heart. See, heart induces the dynamic pressure. It's true that the blood flows into the circulatory system through the mechanical compression of the heart muscles. But when it comes to the question of tissue perfusion, there are many other intrinsic factors, complex factors, which maintain the tissue perfusion, and that peripheral circulatory regulators are also equally important, though not more important than the heart's pumping activity. The major issues are the blood enters into the tissue space from the capillaries, as well as there will be a network over there. Now that in the network which allows the blood to flow to a specific network of the vessels, there is a sphincter, and that precapillary sphincters at the end of the arterioles is one of the major issue, which is also called as glomus. Now the other name for the precapillary sphincters is the glomus, and this is one of the important factors which decides about whether a blood flow to a specific area of the body is required more or lesser. Whenever there is a changing need of the circulation, these sphincters would be acting, and the sphincters would be acting by both local hormonal controls as well as the systemic hormonal controls. When the adrenaline is secreted in the body, all the sphincters, they tend to get constricted, so the total circulation to the periphery would be lesser, and the core blood pressure would be increased. The amount of the blood staying in the vessels would be increased as it are. There could be a selective changes, like when noradrenaline is secreted, all the blood vessels, sphincters, they tend to be constricted. When adrenaline is secreted, there will be a differential issue where the sphincters reaching to the muscles, they will become dilated, whereas the sphincters reaching to the periphery, skin and other organs will be constricted, so that there can be a shift of the circulation to shift of the blood to the muscles when there is a need. So when you do an exercise, the muscles require more blood than the other areas of the body, and that kind of a shift is possible because of the sphincter action. Or so is the case when you take more food. The blood flow to the stomach has to be increased at the cost of maybe the blood flow to the brain or other areas, and so this kind, and this also is regulated by the similar sphincters. So these pericapillary sphincters or the glomi, they have a major role in distributing the blood, and hence to say that it's only the cardiovascular system which are the blood pressure which you record in the major arteries is the only factor to decide about the peripheral circulation is not true. Rather, the tissue perfusion is dependent upon the peripheral finer factors like the plexus and this network of the vessels and the condition of the vessels over there. And of course, the next part of this would be there will be reabsorption of the fluid from the tissue space into the venous end, and then whatever the residual fluid is maintained, produced or left over, that will be drained by the lymphatic vessels. The lymphatic system acts as a additional factor. Now the blood remains as a liquid within the circulatory system. Blood is a liquid, but when there is a need, the blood gets clotted. That there is a mechanism of the blood getting clotted, and we know about that clotting factors, the phenomena of the clotting as such. Now the clot occurs when the blood comes out of the body, within the body. In the normal situation, the blood doesn't get clotted, and the reason for this is there are mainly three factors. One is the pattern of the blood flow. The pattern of the blood flow is what we call as a laminar flow, or concentric fluid layers would occur. When the blood flows in the vessels, the cellular elements, the cells, they will be present in the core area of the circulation. Then the lesser dense components of the blood, they will be towards the periphery, and low dense component will be still more at the periphery. So the component of the blood which comes into the contact with the vessels surface, the mucosal surface, endothelial surface of the vessels, would be comparatively less solid, or it will be more liquid, whereas the central area would be having the core part of the cellular components, and this makes the flow a unique system which we call as the laminar flow. Now if this flow is obstructed due to any reason, that produces an eddies current or abnormal blood flow, and this blood flow pattern can be assessed by the Doppler study, color Dopplers, where the exact pattern of the blood flow and their turbulence or that eddies currents which could be produced, they could be made out. That's one of the factors. Now the blood doesn't get clotted within the body, but when it gets out of the body, when it reaches to the periphery, the blood gets clotted. Now clotting is mainly by two components or two aspects, which is also called as the endogenous and the exogenous, or intrinsic and the extrinsic. The intrinsic factors are when there is a injury to the vessels or any other area, that the injured components or hormones or enzymes which are secreted due to the injury, they will result in the accumulation of the platelets. The platelets tend to get aggravated, and ultimately the platelets get accumulated. They will be releasing prothrombin. The real clotting material is the prothrombin which is presented over there. That will be secreted in, and that prothrombin will be converted into a thrombin by addition of many factors, and these are factors, multiple factors, which continue to, or which regulate the process of conversion of the prothrombin to the thrombin, and the thrombin gets converted into fibrin and fibrinogen and fibrin as such, and it becomes consolidated. That's how the whole clot would occur. That's one, the thrombin pathway. The another pathway is the protein C pathway. Protein C is also another of the factor which prevents this from the clotting. See, which keeps these factors inactive, so that in the normal situation these clotting factors do not get activated. See, the whole process of clotting, if at all it has to be described in brief, is a conversion of prothrombin to the thrombin and fibrin, which is insoluble. Prothrombin is a soluble, so a soluble component of the blood is converted into a insoluble component, and that's how the clot is formed. And then of course the clot would have a fibrinous network like structure, and the cellular elements that would be accumulated over there. But this kind of a phenomena is prevented by the protein C pathway, which will be keeping maybe a control over these factors to do not get activated. So that's one of the issues. Then the other factors which make this clotting becomes clotting abnormal could be, like, mainly there are three components. The one is because of the continuous laminar flow of the blood vessels, uninterrupted laminar blood flow, the cellular elements, the platelets, they do not get adhere to the endothelial surface, and that's one of the factors. Then the other factor is the smooth surface, non-wettable surface of the blood vessels. The blood vessels would have a smooth surface as such, which is non-wettable, and hence the platelets do not get adhered in the normal situation. But if something goes wrong, like if the mucosa becomes somewhat inflamed, endothelial mucosa is inflamed, or it becomes rough, then platelets may get adherent, and that makes the blood get clotted. Then the intrinsic anticoagulant property, that's the protein C, and the other mechanisms. You will have the whole anticoagulant mechanisms in the body. We will discuss that anticoagulant mechanisms later on when we discuss about the bleeding disorder a bit more. So it's mainly the protein C pathway which keeps that blood prevented from getting clotted. Now, the factors, any of these factors altered, can result in a clotting within the body, or what we call as a thrombosis. Thrombosis is a clotting within the body as such. Now, among these, these three factors together are also named as Virchow triad. The Virchow triad are the three components which keep the blood in liquid form or prevent the clotting within the body. If there is any alteration in these three factors, like instead of the laminar flow, the flow becomes turbid, or there is a stagnation of the blood, the flow becomes sluggish, then it can result in the platelets getting, or cellular elements getting towards the periphery, that core portion containing the cells would be, that flow would be affected, and it becomes turbid, and that can result in the clotting. Or a vessel wall injury, if the vessel wall has become rough, that also can result in the clotting. Or hypercoagulability. Hypercoagulability is mainly based upon the presence of the protein C, which keeps that anticoagulant activity. But still another important factor is the viscosity. The ratio between the fluid component and the cellular component of the cells, that also can result in increase in the coagulability, the possibility of the coagulation. So platelet aggregation would occur when the ratio between the fluid and the cellular elements in the blood is affected, and that also can result in the clotting. So these are considered as the three important factors as such. Still, when it comes to the importance, maximum importance, that's even if there are the triggering events, neither venous stasis nor coagulability alone can result in a clinically important thrombosis. From the clinically important point of view, the vascular endothelial injury is the most important factor for the thrombus. So when we discuss about the thrombus, we start with the vessel pathologies. So all that whatever we have discussed is just an introduction. Now we get into the real disease conditions related to vessels, and among the blood vessels diseases, the one condition which is quite known or quite common, and we often see such condition as the vasculitis. Vasculitis is a situation where the blood vessels mucosa is damaged due to multiple factors, inflammation which occurs, and that kind of a pathology is called as the vasculitis. From the clinical point of view, vasculitis is not a single condition, or rather, it doesn't have a similar course. It's not. There will be plenty of causes, multiple causes, which can produce the vasculitis, and from the clinical point of view, this classification of the vasculitis has become now a big controversial or maybe a very complex issue. So I try to make it as simple as possible. So from the point of view of making it simplicity, or from the clinically relevant point of view, I would be classifying the vasculitis into three categories: large vessel vasculitis, medium sized vessel vasculitis, or small vessel vasculitis. Now, as I said, the whole classification is quite complex as such. So, in the simple categories, among those conditions which we may see occasionally, I would be just referring to Takayusu's arteritis in the large vessel vasculitis, Kawasaki disease in the medium sized vessel vasculitis, and Hinox-Schillen purpura in the small vessel vasculitis. We will discuss only these three conditions. Other issues of in detail we will just skip out, because one is most of them are not so clinically common, and the other is there is a significant similarity. It is only about the issue of nomenclature. Now, from the academic point of view, so practically it would be enough if we consider these: the major vessel, minor vessel, and medium vessel and minor vessel classification. But academic point of view, the classifications are quite complex, as I said. The more academic classification is EULAR, or European Union is assessment complication. This classification is as a predominantly medium-sized vessel vasculitis, which are categories like childhood polyarteritis nodosa and cutaneous polyarteritis, Kawasaki disease, and primary vasculitis of the CNS is considered as another. Then small vessel vasculitis are again named as a dendromatosis with polyangiitis, Churg-Strauss syndrome, non-filamentous conditions like microscopic polyangiitis, Hinox-Schillen purpura, isolated cutaneous leukocytoclastic vasculitis, hypocomplementemic arterial vasculitis, primary vasculitis of the CNS angiography negative, and small vessel PSCS. And other vasculitis are named as Behçet cyst, anticlamellar basement membrane or GBM condition, vasculitis secondary to infection. This is somewhat important, like hepatitis B associated nodosa, malignancies, and drugs which can produce vasculitis. So vasculitis associated with connective tissue disorders, Cogan syndrome, and then there is another unclassified. So I think the whole nomenclature is so enormous that it will be quite confusing. So for the sake of practicality, we can just skip off these details, and we limit ourselves only to the major important issues of the large vessel, medium vessel, and the small vessel conditions, and we will be going into the detail of only the three, the Takayusu and Kawasaki and Hinox-Schillen purpura to a certain extent in detail. In general, now, because we will be limiting only out to the specific three conditions, the general signs of a large vessel vasculitis, irrespective of whether it's Takayusu or granulomatous pathology, the common signs which could be seen in the large vessel vasculitis. Now, this I have just made it as a summary to reduce the lack of information, because we skip many of those other conditions. So, the common signs in case of a large vessel disease is that there will be a decreased peripheral arterial pulse, either with or without claudication as a symptom, and a blood pressure difference between the brachial and the lower limb, upper limb and the lower limb difference between more than 10 millimeters of mercury, bruise over the aorta or its major branches, hypertension. These are the common clinical signs of large vessel vasculitis. Medium vessel vasculitis, there will be changes in the peripheral extremities or perineal area where there will be signs of ischemia, and there could be exanthema, scars like appearances or discoloration patches seen over the body, and there could be conjunctival injection, that reddish eyes could be the signs there, and changes in the lips or oral cavity, again due to that injection or injection in the sense reddish spots there, or cervical lymphadenopathy could be the other signs. So in the small vessel vasculitis, the more common would be prominent involvement of the lower legs with the pure lesions in the proximal sides close to the body, palpable purpura or non-purpuric erythematous or urticaria like wheals seen, hemorrhagic bullae, necrosis and superficial ulceration or local itching. These could be the common signs of all or majority of the small vessel vasculitis. Among these conditions which we see in the clinical practice and which we treat, henox-inline purpura, we see a relatively larger number of patients, whereas large vessel vasculitis, they are rarely seen in our routine clinical practice. But still, we will discuss each of them. Now, as far as the etiology of vasculitis in general is concerned, the most common etiology for the vasculitis is autoimmune pathology. And autoimmune pathology is, again, the real causes of the autoimmune pathology are not known. And hence, most of the times, the exact cause for a vasculitis cannot be made out. The other conditions which can produce the vasculitis are secondary vasculitis, and secondary vasculitis could be due to multiple causes like tuberculosis, streptococcal infections, mycoplasma, syphilis, HIV, herpes simplex, varicella, or any other virus like Epstein or cytomegalovirus or parvovirus or hepatitis virus conditions, or candida-like conditions, or systemic rheumatic diseases like SLE, Sjogren's syndrome, sarcoidosis, even dermatomyositis, or malignancies like there is a typing error. This should not be there. Malignancy and hypersensitivity. There was a bit typing error. So malignancy and hypersensitivity also can be a cause for the vasculitis. As far as a patient of vasculitis coming to you, the exact cause to be made out is often difficult. But if there are any definite evidence of other previous illness like tuberculosis to the hypersensitivity, we may consider this as an issue of the secondary vasculitis, or otherwise vasculitis patients are mainly autoimmune. The types of the pathophysiology produced due to the vasculitis could be of different categories, and either it could be again based upon the pathology, again it's classified into many types like lymphocytic giant cell mediated vasculitis, where there will be a thicker vessels involvement and the vessel becomes fibrous later on, or necrotizing vasculitis, where there could be really necrosis of the tissue as in case of Kawasaki disease like conditions, or then antibody mediated vasculitis, and those conditions are there will be deposition of the antibodies. Antibody mediated vasculitis are mainly the autoimmune vasculitis conditions. So pathophysiology can be classified as such. With that's about the general issues about the vasculitis. Now we go into certain specific conditions. Among them, Takayashi's arteritis or Takayashi's vasculitis. It's a rare condition, and it's a systemic inflammatory large vessel conditions, inflammation conditions. Often it's as a granular matters inflammation like tubercular. The exact causes are not known. It's an unknown etiology, and it affects women more frequently than the men, and women in the younger age, childbearing age, are more frequently involved than others. The total 1 minute. Just I'll come back again in 2 minutes. Now the incidence is comparatively low as 2.6% per million annually. So it's not, and comparatively in India, among the Indian conditions, as per the universal data, uh, this incidence in India is also common among the Asians. Indians also have common, but as far as my clinical exposure is concerned, we have rarely seen such patients of tachyarthritis arteritis. And there is another difference noted as per the academic data. Japanese patients would have more of aortic arch involvement, whereas Indian patients have more of abdominal vessel involvement. This is based upon the report as such. Comparatively, what we see in our routine conditions, it's not very common. And approximately 80% of the patients with tachyarthritis are women. The symptoms of vasculitis, tachyarthritis arteritis, are the initial symptoms which present with the systemic involvement would be headache and good number of patients, malaise in 35 to 65% of the patients, arthralgia, pain in the joints, fever, weight loss, which would be the initial constitutional symptoms. But more important will be cardiac and vascular features, signs of the blood vessels. The most common clinical sign will be patient with the hypertension. Patients initially would have some fever-like condition, which often resembles that of a viral pathology, and then later it presents with the cardiac symptoms as such. And among them, the first of the symptom would be the hypertension. Then there could be valvular defects which could be produced, like aortic regurgitation can occur, and the blood pressure difference between the extremities, that upper limb and lower limb blood pressure differences, and murmurs could be heard over the carotid artery, which is also quite common among the conditions. Symptoms of claudication and symptoms of tenderness over the blood vessels become thickening and tenderness of blood vessels, or Raynaud's phenomena, peripheral ischemia, pericarditis, even congestive cardiac failure, myocardial infarction can occur in a few of the conditions as such. Then the other neurological features can occur, like visual disturbances and stroke-like symptoms, or even transient attacks. Seizures also could occur. Skin manifestations like erythema, ulcerated nodular lesions, pyoderma gangrenism also can occur. First conditions can also occur in case of the tachyarthritis arteritis. Now, because of this widespread set of clinical symptoms, it's often difficult to make out the diagnosis, and it also has a rather varying course, like initial course will be different and later on the course will be changing, and because of that, the diagnosis of tachyarthritis arteritis is based upon mainly the 6 criteria according to the American College of Rheumatology classification. And that's the criteria are age of 40 years or younger at the disease onset, claudication of the extremities, a decreased pulsation of one or more brachial arteries, differences of at least 10 millimeters mercury in systolic blood pressure, brew over one or both subclavian arteries or the abdominal aorta, or angiographic involvement of the entire aorta, where the aorta has become edematous. Blood flow is turbid. That's the other evidences. Or later on, it can present a fibromuscular dysplasia, that the whole arteries become thickened, or maybe a very, not due to the sclerosis, but the whole vessel wall becomes thickened and rigid. That kind of an evidence seen in the angiography are we considered as the criteria for diagnosis. When any of the 3 of these 6 are there, that can be diagnosed as tachyarthritis arteritis as per the standard methods of diagnosis. Now, the tachyarthritis arteritis also is classified based upon the location of the vessel which is involved, and it's categorized as a type 1, type 2A, type 2B, and type 3, type 4, and type 5. The type 1, it's the branches of the aortic arch. There will be the thickening involvement. And type 2A is there is an involvement of the ascending aorta and the aortic arches and its branches. Type 2B is where the second A region plus thoracic segment. The second A plus thoracic segment is seen. Type 3 is thoracic descending aorta is involved, where there will be this thickening and the ischemic changes. Type 4 is where abdominal aorta is involved, and as per the typical data, in Indian conditions, type 4 is more common. Abdominal aorta and renal arteries are involved, or both. Then type 5 is where the whole aorta throughout and its branches, type 5. Type 5 is where the whole of the aorta is involved. That would be the classification of these conditions. Now, as I told you earlier, the course of the disease would be presented as in 3 stages. That's the important issue, and it's always difficult to make out the diagnosis in the initial stages. The first stage is but it's also called a systemic stage. The patient would mainly present with the constitutional symptoms like fatigue, malaise, giddiness, fever, where it's always difficult to make out the condition. It's usually diagnosed as some viral fever, low-grade viral fever in the initial stage, where there will be no evidence of a vascular involvement. The second stage occurs when the patient would have vascular inflammatory stages, where either stenosis or aneurysm or pain in the vessels would occur. Along with the fatigue and fever, malaise and symptoms, joint patients, patient may have dyspnea, palpitation, headache, rashes, erythema over the body, or lupus like butterfly rashes also can be seen, or hemoptysis, ulceration, weight loss. Now these are the stages where you may suspect these complications. So any febrile patient with a initial history suggests of fever, which we usually consider as a common viral fever. If the patient develops these signs of vascular involvement, usually by the end of first week, usually it occurs by 6 to 7 days, like the second stage symptoms would occur, and at that stage it may be possible to make the diagnosis, and that's the critical stage. That stage is the critical stage where major complications would occur. In the later stage, that's also called the burned out stage, where the patient would have gradual recovery. There is a majority of the patients would have gradual recovery from these systemic symptoms and the other symptoms, but the vessels become fibrosed, and as a result of the fibrosed vessels, patient would have hypertension, or later on cardiovascular complications could set in as such. Now, laboratory test results are non-specific. There is no definite method of making the diagnosis of Takayasu's disease by any biochemical parameters. The usual reliable, somewhat reliable tests are the ESR, where it is very high in the initial stages, but later it becomes normal. Then autoantibodies, anti-nuclear antibodies, they also are seen in a good number of patients, and among them ANCA, that anti-neutrophil cycloplasmic antibodies, they have a higher role to make out, and rheumatoid factors or anti-cardiolipin antibodies also may be presented in these conditions. Recently, HLA-B52 is also now one of the genetic type. HLA-B type is also now considered as one of the biochemical parameters. But the actual diagnosis of Takayasu's arteritis is to be done only with the angiography, where the vessel wall thickening and irregularity of the vessel wall can be made out. So most of the times in our routine clinical practice, we may miss these cases, or the patient may have to refer to other higher center for the diagnosis when we do not have the facility of arteriography. As far as the treatment is concerned, the mainstay of the treatment is corticosteroids, and in Takayasu's arteritis, usually the oral corticosteroids are started at 1 milligram per kilogram daily in divided doses, and then tapered over weeks or months as the symptoms subside. And low dose corticosteroid therapy may be required occasionally for the whole time. Other drugs are the immunosuppressant drugs like rituximab or trastuzumab, also are cyclophosphamide. These are prescribed occasionally, but the most important is management of hypertension or renal damage or cardiovascular management. We may get a few of the patients with chronic hypertension with this kind of fibrosed vessels, where the exact cause of Takayasu's might have been missed. See, what happens is many of these old patients, relatively younger patients, presenting with hypertension and renal damage, we make the diagnosis of hypertension and renal damage and we manage accordingly. But the real cause for the hypertension and the renal damage might be missed because the patient might have developed a tachysis arteritis and has crossed the first and second stage without really reporting to us, and the patient may come to you at the third stage, and at that condition this original basic pathology would be missed as such. Then the other possible options of the treatment could be surgical treatment if the vessels are severely constricted and if they require a bypass graft may be necessary. That's about the tachysis arteritis, one of the examples of a major arteritis, and from the clinical point of view they are not very common. We see very rarely with few patients, maybe in the only later stages, not in the early stages. The next of the condition which we may see quite somewhat frequently is Kawasaki disease. We have treated a few applications in our hospital also, Kawasaki disease. So this is another of the condition, and it's also known as a muscular cutaneous lymph node syndrome or Kawasaki syndrome. It's presented as an acute febrile illness of early childhood and characterized by vasculitis of medium-sized arteries, as well as there will be lymph node enlargement of the lymph node also are seen. And from the clinical point of view, there are two common categories: complete and incomplete. Complete this Kawasaki disease requires a diagnosis. For the diagnosis should be at least 5 days duration with the 4 or 5 of the clinical features, and the principal clinical features are changes in the extremity, polymorphous rashes, like where there could be multiple rashes over the body, the changes in the oral cavity where there could be ulcerations or injection spots, or characteristically conjunctival injection also, with the maybe bulbar conjunctival injection. There will be the whole eyeball will be reddish as such, or the unilateral non-purulent cervical lymphadenopathy, the lymph node diameter of greater than 1.5 centimeter. Patients presenting with a fever, persisting for 5 days or beyond, and lymph node enlargement, conjunctival this injection reddish conjunctiva, or rashes over the body, you have to suspect Kawasaki disease. Then incomplete KD is the other way, where the patient would have a fever for 5 days or longer, and mainly the 2 or 3 clinical main features among them, mainly the lymph node enlargement, would be often seen as such. That is, our ECG changes also can be seen. The etiology of Kawasaki disease is not known again, but a strong suspicion that it is of infectious origin is the strong suspicion, because there will be purulent changes in the lymph node, but no specific organism is yet identified. So autoimmune reactions and genetic predisposition have suggested as a possible etiological factors at present. So at present, Kawasaki disease, the exact etiology is not known. The main issue is ECG. ECG is to be done ideally 1 to 2 weeks after the onset of the illness and 5 to 6 weeks after the onset of the illness. Again, it could be at the time of the Kawasaki disease diagnosis, because there is a possibility of coronary artery involvement. To evaluate the coronary artery circulation, ECG is considered as or echocardiography. So echocardiography also is considered as one of the reliable methods by which you can make the diagnosis as well as assess the course of the disease as such. The other clinical signs of Kawasaki disease which we may see would be the rashes, the typical rashes in the Kawasaki disease, or at the extremities. Again, there could be peeling of the skin and then the rashes, reddish rashes at the fingers, or changes in the tongue where there will be reddish spots on the tongue, and infiltration, that is injections like signs, could be the other evidences of Kawasaki disease. Once you have made the diagnosis of Kawasaki disease, the principal goal of the treatment is to prevent coronary artery disease as such. The standard protocol of the treatment is an intravenous immunoglobulin, which is a purified preparation of thymoglobulin and aspirin are the mainstays of the treatment. In major hospitals, it could be done. But we have treated a few of the patients with the Kshara Aragavardhini Manjustra Vata and Manjustra Ksharamasti effectively without even these immunoglobulin conditions. And as far as the immunoglobulin condition, prescription is concerned, the protocol is it should be given within 10 days after the onset of the fever, but given later it will be of relatively less used, and it's claimed that the immunoglobulin given would be preventing the cardiac complications as such. So that's about the Kawasaki disease as such. The next part is henoxylline purpura, which we will discuss in the next session. So we will stop today. If there are any questions, I will try to answer. Right. So